Hello.
Yes, Sachin.
Yes, welcoming all of you. I will start the program now. I first of all welcome all of you from ISA Nanded. This is our case meet 10, interesting case discussion. Uh, Madam's introduction, I will first start it. Currently, Madam is working as a specialist anesthesiologist at Al Qasimi Women's and Children's Hospital, Sharjah, UAE. MD anesthesia completed from Tokyo Nair Medical College, Mumbai University in 2007. In Nair Hospital, had got opportunity to work in almost all faculties of surgery: general surgery, obstetric, cardiac, neurosurgery, and pediatric surgery. And she was my senior and lecturer also at that time. And now practicing obstetric and pediatric anesthesia. Special interest is epidural labor anesthesia. In 2018, got European diploma in anesthesia and intensive care edict. Her publications are a national publication in Bombay Hospital Journal related to obese patient for PCNL in prone position, a case study. Second one was the effects of propofol, ephedrine combination and only propofol on the intubating condition of rocaridum, a randomized controlled study. International publications, renal transplantation in a patient of aorta arteritis with aneurysm of abdominal aorta. Thank you all. Please, Vidya madam, you start the presentation.
Okay, Sachin. Thanks for introduction. You can hear me?
Yeah, just increase your voice volume.
Okay. Yeah, now is it okay?
Yes. Please start.
Okay. Yeah. First of all, I thank ISA Nanded for giving me this opportunity. Today, my presentation is about a patient who is 33-year-old. She is she is G3P2 with 7 months pregnancy. A known case of pregnancy-induced hypertension and gestational diabetes. Obese patient with weight of 120 kg. She admitted to our emergency with difficulty in breathing and case of COVID pneumonia. She required prolonged mechanical ventilation, and here we will discuss what problem we faced while treating her and how she responded to our treatment. Now, on the day of admission, uh, she brought by national ambulance. On examination, patient was
Please start
obese.
your slide, Vidya.
Yeah, slide is there. You cannot see.
No, not opening. Only first slide is there.
No, this is second slide. See, this
No,
is
it's
third.
not running.
Okay. Can you see?
No. Only first slide is there.
Really?
Start the slide.
I can see. I am changing my slides.
But not here.
Now, wait. If now can you see?
No. Click on second slide.
This is second one. I am clicking.
No, nothing is there.
Now what? 1 minute.
Please click on share. Now it came.
Okay, so this one.
Make it big.
Yeah, now you can see second slide.
Yes.
Wait,
start the
now
share slides. Yes. You start the.
This is first slide.
No. Above upper right side.
Okay, 1 minute.
On your left side there is share.
Okay, wait.
Share.
Now, okay, can you see second slide?
Yes. Introduction to case.
Yeah. Okay. I will keep it like this.
Okay.
Okay, I will keep it like this. Is it okay now? You can see the slide?
Just speak loudly.
Okay. Now you can hear me.
Yes, yes.
Okay, so let's start the case now. On the day of admission, she was brought by a national ambulance, and on examination, she was obese patient with 120 kg, and she was tachypneic and sweating. She was febrile with high blood pressure, and SpO2 was only 68 with non-rebreathing mass. Krebs and Ronca were present. So we administered medications, furosemide, paracetamol, salbutamol inhaler puffs were given, dexamethasone was given, and ABG was sent. It was respiratory alkalosis with PO2 only 56. After giving all these medicines, her SpO2 improved to 80%. Then she was shifted to ICU and she was put on non-invasive ventilation with pressure support of 15 and FiO2 of 80. Okay, Sachin, now is it okay?
Yes, you did. Yes.
Okay. Now this is the X-ray on the day of admission. Only upper lobes, we can see only upper normal lobes, lower lobes, and these they are all infiltrated. Next day, we decided to give her a chance of non-invasive ventilation for next 24 hours as she was tolerating CPAP and her blood gases were showing, they were stable with and showing serial improvement in PO2. But on third day, patient was taken for emergency LSCS in view of abruption. So she was intubated in ICU and was shifted to OT. Now, in OT, you can see the parameters. This is the chart. The blood pressure, heart rate. They are at the start of. The case. Here, blood pressure and heart rate, they are stable. But if you see SpO2, it is at the start of case, it is around 80 to 77. And with peak, and she required peak high peak inspiratory pressure. So this is the chart. This is intraoperative chart. You can see heart rate and blood pressures are stable, but SpO2 it was 80, but after some time it started following and it was low throughout the operation. So what went wrong here? After the delivery of baby, anesthesiologist cannulated right internojugular line, and after some time airway pressure started increasing. There was a fall in saturation. So and there was a continuous fall in saturation, so immediate portable X-ray was done. A right-sided chest was not moving, so this pneumothorax was suspected and needle aspiration was done by anesthesiologist. Then after portable X-ray, it was right pneumothorax, so immediate right ICD was inserted. And in spite of inserting right ICD, saturation was still on the lower side and it remained low throughout the surgery. So in between, this blood gases was done and PO2 was only 29. There was one episode of pulseless electrical activity, which for that one dose of adrenaline was given, and she responded to that. As the other parameters were stable and saturation was not coming up, so we decided to shift the patient to ICU with this saturation. So that time, while shifting, the saturation was around 60. Now this is the X-ray which was done in the OT. Here you can see the right internojugular line and the right pneumothorax, and then this is the X-ray. You can see the right ICD. After right ICD insertion, the SpO2 was still on a lower side. But when patient was shifted in ICU, after some time with ICU ventilator, she started picking up the SpO2 and it came up to 88 to 90. She was kept on ventilator, sedated and paralyzed. Pupils was, pupil was checked, and they were equal reacting to light, because she tolerated so much hypoxemia in OT. So next day, neurological assessment was done. For that, for time being, sedation and paralysis was stopped, and she's just for neurologically, just she started opening her eyes, and she tried to show response. But after that, we again continued her mechanical ventilation with sedation and paralysis. Now, after this episode, she was there in our ICU for next 2 months. During these 2 months, here we will discuss what problem we face while treating her. So these are poor oxygenation in spite of high FiO2, all the time fluctuating and rising blood pressure. Then she went into septic shock. She developed pneumothorax again in ICU. Eventually, she required tracheostomy, and then critical illness, myopathy, and neuropathy. So first, coming to poor oxygenation in spite of high FiO2. In case of severe ARDS, the aim for PO2 is between 55 to 80 with permissive hypercapnia. So in this patient, this chart shows the PO2 and FiO2 with PEEP for first 18 days. So in this, we try to maintain her PO2 around 60, but you can see this red one is a PO2. Here all the time she required very high FiO2, 80, 85, 90, and with PEEP ranging from 13 to 10. Now after this is for first 18 days. Now 19th and 20 days, the her FiO2 requirement was even increased. So we increased FiO2 for first 2 days, hoping that once she will pick up the PO2, we will start decreasing FiO2. But in spite of increasing FiO2 to 100%, and for next 12 days, her PO2 was still around 60, means 50 to 60. So because her PO2 was not improving, we tried other techniques like lung protect, these were going on, like lung protective strategies. We tried lung recruitment maneuvers given, lateral position was given. In this case, usually prone position is supposed to be the good position for improving oxygenation, but because her cesarean section was done and it was abdominal surgery, and it is relative contraindication for prone positioning, so we tried extreme lateral position for her, and also we kept the option of ECMO ready. Then we realized that even after 12 days, her saturation was not improving with 100% oxygen. We decided to accept low PO2 values, and over a period of next 7 days, we started decreasing her FiO2 slowly. So fortunately, here PO2 was not decreasing; rather, it was stable. So this means after 45 days of intubation, we succeeded getting her PO2 70 with FiO2 60. We all know that oxygen is toxic to lungs when it is given in higher concentration and for a prolonged time. So in subsequent slides, we will see what happened to her lungs. Now, another problem was fluctuating and rising blood pressure. This is the chart of first month of her admission. These numbers are the numbers showing antihypertensive agent she was on while treating her blood pressure. So first 10 to 15 days, her blood pressure was controlled with 2 to 3 antihypertensive agents. As I said, when at the time of admission, her blood pressure was high, so she was on continuous labetalol infusion, and after 15 days, her blood pressure started rising again. So that time she was kept on 5 antihypertensive agents. Now here you will see there is no antihypertensive agent. This is the period where she developed sepsis and she was on noradrenaline infusion. But luckily she came out. This is the chart of next month, means second month of her admission. And you can see she came out easily from the relatively easily from sepsis, and again blood pressure started rising, and she was on 5 antihypertensive agent for some time. Then slowly her blood pressure got stabilized with 4 antihypertensive agents. So now, what is the reason for this high blood pressure? There is something called resistance hypertension, where usually essential hypertension they can be manageable with 2 to 3 antihypertensive agents. In resistance hypertension, when 4 or more antihypertensive medications are required, it is called resistance hypertension. And the most common risk factors are old age, obesity, obstructive sleep apnea, immobility, female sex, and diabetes. So in this case, yes, of course, she was obese patient, and we tried to rule out other causes of hypertension also. So ECG 2D echo was done to see left ventricular hypertrophy if it is long standing hypertension, and a bedside renal Doppler was done, but it was normal. So we treated her as a resistant hypertension. Now coming to the next problem. Um, as I said, this is the after 20 days she started getting fever because sepsis in ICU. Patient who require prolonged ICU stay, they are very prone for getting fever and sepsis because of these catheters, urinary catheter, internal jugular lines, ICD, intratracheal intubations. All these factors sometimes become the source of infection. So in this patient, this is the same chart where she was on antihypertensive agents, and this is after 20 days she started getting fever. So here all antihypertensive agents, we withheld all antihypertensive agents, and noradrenaline started as she developed hypotension. At this time, all pan cultures were sent, and antibiotics started. We tried to change. We decided to change jugular line. Arterial cannula was removed. Urinary catheter was changed. So now this is the picture which shows this February 4th to 26th. Almost this is the chart where in these 2 months she received um, antibiotics for different for different culture sensitivity organisms. So out of these 2 months, almost 42 days she was on antibiotic. At the time of admission, she was started on ceftriaxone and clarithromycin. And as I said, after 20 days she started getting fever, and this was a period of septic shock. She was on noradrenaline. That time, first empirically meropenem and cholesterol started, but that ICD, as I said, the pan culture was sent. ICD side culture was showing culture came positive for pseudomonas. So, and it was sensitive to piperacillin, so piperacillin was added. Then amikacin added because still she was getting fever. After some days, again urine culture came positive for fungal infection, so antifungal added. Then every 15 days, like, she was getting fever. Then pseudomonas came positive. Sputum culture was positive for pseudomonas. For that, she was started on piperacillin. Imipenem added as she was getting fever spikes. And then she again developed pneumothorax of left side. So that time left ICD was there in her for some time. That time she that wound side culture came positive for Klebsiella. For that, gentamicin was added. Then again for bacterial vaginosis, metronidazole. So almost all these um, uh, you, you know this all these sensitivity tests were done, and culture sensitivity tests were done, and antibiotics were given timely, so that helped her to come out of sepsis easily. Now, yeah, now coming to next problem. After 20 days, as said before, she started getting fever. So we decided to change her jugular line. And before removing right jugular line, we wanted to cannulate left jugular. But while cannulating, she developed left pneumothorax. Um, so then this is the X-ray of left pneumothorax. Then again, ICD was inserted for her. This is left ICD, right ICD is there, and right jugular is still there. So this, but uh, yeah, now this is the next time. Till now we realize that this patient is going to require will require prolonged ventilation, so we decided to go for tracheostomy. Now the criteria for tracheostomy was uh, high means low PEEP and FiO2 between 50 to 60. So that we achieved almost after 1.5 months of struggle. And after 1.5 months, tracheostomy was done. So this is the X-ray which was done after 3-4 days of tracheostomy. Now, after tracheostomy, there was drastic improvement in her health. Um, this so then we decided to her PO2 was normalized. She required less PEEP. Neuromuscular agent were discontinued. Sedation doses were reduced. Neurological examination done. That time she was conscious oriented. She was well oriented to the surrounding, and but she was unable to move her four limbs, and it was quadriparesis. Now conduction studies performed, and they showed critical illness myopathy and critical illness polyneuropathy. Now what is the risk factor for this? Sepsis, female sex, she was on a vasopressor administration, she was on steroid also, dexamethasone, and prolonged neuromuscular blockade. So we tried to replace neuromuscular agents by replacing with by adding remifentanil and Presidex, but because her oxygenation was very poor, and she required high PEEP. So for high PEEP, neuromuscular agents, that was we added neuromuscular. It was difficult to discontinue neuromuscular agent, so she required this agent for 45 days. Maybe because of that, she was not unable to move her limbs. um, yeah, but after this neuropath, after diagnosis of this neuropathy, she was put on intense physiotherapy. Coming to the next slide, these are some important points I would like to discuss. During this, at least for first 1.5 month, she received nutritional support as a enteral feeding. Then she was on diuretics to deal with her positive balance and keeping her lungs dry. Then in ICU patient, electrolyte imbalance is very common. In this patient, we saw hyperkalemia, and it was treated accordingly. Then lorazepam, she needed anxiolytic lorazepam because patient was feeling little depressed when she got to know that when she got to know about her illness. She was here since so many days, separation from the family members. So we kept her on lorazepam for 15 to 20 days. Now enoxaparin was started from the first day of her admission, and because she was immobile for so long, we did venous Doppler also, and it came normal. MRI brain we wanted to do, but we could not do because of her critical condition. In OT, she was with that profound hypoxemia for a long time, but MRI was not done because of her critical condition. Now, next slide. Okay. After tracheostomy, as I said, she showed a drastic improvement. And slowly over a period of 15 days, the weaning started from tracheostomy, from SIV to CPAP and then TPS trial. And she was there with tracheostomy for 15 days, and then wound was closed after 15 days. After that, she was on nasal prongs, and for myopathy and neuropathy, intense physiotherapy was given, and she recovered within 10 days from the with this myopathy and neuropathy. And this patient was discharged on 17th day with nasal prongs, 1 to 2 liter oxygen with enoxaparin and antihypertensive agents. So this case, from this case, we hello. Yeah, from this case, we learned a lesson. Do not disturb ventilatory settings while shifting the patient from ICU to OT. Because this patient was on ICU ventilator, then we shifted her to OT and kept on OT ventilator. So there was a lot of desaturation episodes were there. Then after that, after this case, we conducted many cesarean sections with corona positive, corona pneumonia patients, COVID pneumonia patients, and that time we all patients were shifted from ICU to OT with ICU ventilators without disturbing any setting. So that helped us to prevent desaturation events. Now here, two times patient developed pneumothorax. One is in the OT, one is in the ICU. So we realize that diseased lungs are really very prone for pneumothorax. So whenever possible, avoid jugular lines in this case. We can go for femoral lines. And of course, good teamwork with never give up approach. Good teamwork, because here everybody worked very hard, and especially our nursing staff, because patient was there for 1.5 months. They were working with PPA for hours together. Patient even didn't get one single bed sore. So that was really very appreciating for them. And third, other factor is some patient behave really differently, and this was really a miraculous case for us. Many time we thought that we were doubtful whether she will make out or she will make it or no, but yeah, she came out, and we consider her as a miraculous case. This is our team, ICU team. This is the picture taken on the day when patient was off ventilator, and now she is only on oxygen with TPs. Our respected Dr. Hind, she is our HOD, very supportive, and this is our nursing staff, our anesthesia doctor. This is the letter written by our patient when she was about to discharge from ICU to ward. And you can imagine this is the same patient who admitted with 68% saturation. Then she developed pneumothorax in OT. Code blue was announced for her. She was there in OT for almost 2 to 3 hours with the PO2 of 29 and SPO2 of 30. Then shifted to ICU. There she developed again pneumothorax, gone through multiple antihypertensive agents, for high blood pressure, multiple antibiotics, septic shock, then critical illness, myopathy, and neuropathy. And as I said, it is really a miraculous case for us. And this patient came after 1.5 months for follow-up. You can see her X-ray after 1.5 months. This was taken during that time. So when she came, she was off oxygen. She was on room air. Her room air saturation was 96%. Now she can walk without support, and she was on antihypertensive agent, amlodipine and valsartan. So thank you all. Thanks everyone for listening to me patiently.
Nice presentation, Vidya. Very good case. I want to ask one question on this. Why you did late tracheostomy in this case?
Yeah, because as per ENT surgeon, they said they cannot do tracheostomy with very high PEEP. So that was one reason, and of course FIR2, FIR2 they wanted between 60 to 7, between 60 to 50. With high PEEP, of course, they were scared to do this tracheostomy.
Okay.
Because as per guidelines, the criteria for doing tracheostomy is a low PEEP and saturation FIR2 between 50 to 60.
Okay. Vidya, can you off your presentation? And
Okay.
okay,
Yeah.
so you can see all of us.
Okay, wait. Okay. Sachin?
Yes, close your sharing.
Okay, okay.
Yes.
Okay now?
Yes. Two questions are there from Dr. Pawan Tayde has raised a hand. Pawan, please ask.
Hello.
Yes.
Hello. Hi, I'm Pawan here. I just wanted to ask, there was a mention of pulseless electrical activity inside the OT.
Yes.
Hello. Am I
Yes.
audible?
Yes,
So
yes.
there's mention of adrenaline, but there's no mention of any like chest compression or resuscitation.
No, it was very transient. It was less than 30 seconds. We saw it heart rate going over 160. There was no pulse. Quickly, adrenaline was given. She responded, and pulse came back. So there was no need of ECM that time.
Okay. Other question I would like to ask, whether you do ultrasound of chest, like ultrasound chest, to diagnose pneumothorax. Anybody is there? So because these are all tertiary care high-end hospitals. So was there any ultrasound used to diagnose pneumothorax inside the OT?
Yeah, we do, but because this situation, you can imagine the situation. It was a very stressful situation, and it was obvious clinical diagnosis. Chest rise. There was no chest rise on right side, no air entry, and right side chest was not moving at all. So it was obvious that it is the right pneumothorax. That is why I said needle aspiration was done by anesthesiologist. By the time portable X-ray came, and yeah, it was a clear cut diagnosis on chest X-ray. So uh, sonography
Okay.
was not done.
Okay. Thank you, ma'am.
Welcome, sir. Samir sir is joined now. Samir sir is our state official. Praveen sir, Praveen Ubale sir, you have any question? I think Praveen is off on audio. Anyways, any question from audience? Please ask.